Hi, I'm Leslie Davis. I'm a nurse practitioner and a nurse scientist, and I'm joining you today from CARPS in San Diego. It's actually a very beautiful day, but it's more exciting inside today at our sessions. And I just got through talking about hypertension and the latest guidelines in the last year. So it was very well received, but if I had to do 3 takeaway points from the talk today, one is that we have a brand new classification of what's hypertension. That hasn't changed in decades, but in the last year, blood pressure or high blood pressure is now considered 130 and above, over 80 and above. Now the 130 versus the 140 is changing what we do in practice. Now it's not a mandate just because they now have hypertension with the new classification at 130. It's not a mandate for pharmaceuticals, but it is a wake-up call for us and patients to go ahead and make sure we start lifestyle changes and see if they need medications. But we have a new line in the sand with 130 versus 140. A second key point that we made is, well, the numbers are even more important than ever. So make sure the blood pressure numbers are correct. It's not just that 1 or 2 readings in the office, because you're making huge decisions about not just lifestyle but pharmaceuticals, that we need to make sure the number's correct. And what that means is not just a slice of time in our office, but doing blood pressures outside the office. We're making sure they don't have white coat hypertension. We've all known that for a long time, but also that they don't have mask hypertension. In other words, it might be a lot higher outside the office. So we need a combination of in-office and out-of-office readings as we make the determination whether they have hypertension or what we need to do with therapies to meet goals. And if I had to say one more takeaway, and there's many, but one more takeaway is, how do we know how low to get the blood pressure? What's the goal? So for the average adult, less than 130 over 80 is going to work. But the new guidelines from 2017 say we actually need to calculate their cardiovascular risk. So their atherosclerotic cardiovascular risk needs to be, if they have a history of cardiovascular disease, anywhere head to toe, then we need to be below that 130 over 80. If they don't have a history of it, but you do the risk calculator and they're 10% or higher chances of having an event in the next 10 years, then that's almost like a risk equivalent. So they too need to be below 130 over 80. And then, so they don't have a history of CVD. The risk calculator says they're not 10% or higher having a likelihood to have an event in the next 10 years. Well, those can have a goal of less than 140 and less than 90. However, experts say if you want to make all your patients or have a goal of less than 130 over less than 80, that's not bad. But those low-risk patients, you really can have a conversation with the patient and see what works for them. And that's all. So goodbye from San Diego.